Good morning, everyone. It was Kraków. For those who are not from here, fantastic city. I'm not from Kraków, so I can be much more objective. I fell in love with this city. So thank you very much for coming, especially those who came from outside Kraków. We will talk, we will join and discuss ideas from the dental field. This is the first time in history of life sciences open space that the Dent Tech session is organized. Usually it was in a so-called key technological cluster in Poland, in Kraków, is devoted to health in general sense, but it's never been the session, there was never a session devoted to dentistry. I participated a few months ago in a session that was devoted to, I think, in general health issues, and I realized we dentists, I'm a dentist, orthodontist, we deserve more. So after 1 year, we have a Dent Tech session. We have a rich program, although we have one small problem. One of the speakers is ill. Let me have a look at the schedule. I think who will be missing? Michał Iwański. He was supposed to present just before 11 o'clock, and he was supposed to talk about DentScriptor. That is revolutionizing dental radiology reporting. So we will miss him. He's not with us. Hopefully, in the future, he will join us and present his presentation. Life Sciences is about collaboration, is about matchmaking, creating a space that scientists, clinicians, dentists, innovators, and hopefully those who can finance our ideas get together and create environment to bring our discoveries, our inventions into life, to bring them into project. So what I would like to talk about at the beginning, it will be a short presentation. I titled my presentation Opportunities and Challenges in Dentistry and Craniofacial Surgery. So I would like to draw a landscape for those who would like to invest in a very broad sense in dentistry. In Poland, there are more than 30,000 practicing dentists, but the dental business is fragmented, is decentralized. So most dentists, they work in rather small practices. There's a tendency toward creation of group practices of larger companies that are hiring dentists, but still most of patients are treated in small dental practices. When we think about the dental business, then we should always remember the trends that are movements that are taking a long time. And those trends I would like to identify. These are subjective identification of trends in dentistry, and just discuss them briefly. So from my perspective of a clinician, also researcher, I see the trend in demands and expectations in technological advancements, also simplification of treatment techniques, the need for evidence-based treatment, also demographic trends, and fast or instant exchange of information. When I graduated from the dental school, that was in 90s, almost all patients came to me. Maybe not all, but very many of them, a large proportion of patients came with pain. The tooth or teeth were about to explode. There's inflammation. So patients, very many of them, had to take antibiotics or painkiller, and they had to come back for so-called intervention treatment, for some kind of treatment that would alleviate the pain. So this was intervention dentistry in most cases, 35 years ago. Over the years, it has changed, I would say dramatically. Now, aesthetics is the prime factor for patients to ask for treatment. And it's almost impossible to find a website of a dentist, of a big clinic, without smiling face. The teeth, a nice smile, attractive smile, is a key. This is what dentists say. But if you ask psychologists that are involved in research about facial attractiveness, psychologists will tell you dentists are not so one-sided. They have the point. If you are attractive and the focus of beauty, the place how we recognize if someone is attractive or not so, is the face. If you're attractive, if you're perceived as an attractive person, you get a lot of benefits from life. You get better marks in the school, at the university. You have more children, you get married earlier in life, and so on and so on. So it pays off to be attractive. And when we look at someone for the first time and assess facial attractiveness of a person, we look at the face, eyes, and the region of mouth. So yes, we are needed as dentists. And can you imagine that Ronaldo could make such a great career without dental treatment, without improvement of aesthetics? It's impossible. He probably could have played also good football. But as a commercial icon, he wouldn't be so successful. Don't you agree? And for that reason, I think, almost 3/4 of Dutch teenagers are treated orthodontically. And this increase, that was from 45% to 74%, happened over the last 15-20 years. They, in Western countries, in Western Europe, I mean teenagers, their parents, traveled this journey many years ago, and we will be traveling here in Poland, or we are traveling here in Poland right now. I'm sorry. So the big trend in dentistry is the requirement, is the demand for aesthetics. Another trend is technological advancement, and this is just a banal thing to say that we are immersed in technology right now. And one of the examples are orthopantomogram in the past and 3D imaging possibilities right now. We can see much more, we can identify many more details. We can identify here in this example, we have a tooth that is impacted. Oh, I'm sorry. Oh, it's a little bit. So we have a tooth that is impacted here, and this impacted tooth can cause a damage to this one. It's impossible to see, to assess the amount of damage or if the damage is there on 2D radiographs. Three-dimensional radiography gives us many more details. And probably the most palpable technological change in dentistry is scanning. I remember times when I had to take impressions. Then we poured the plaster models. We never threw them away. And after a few years of practicing, you had piles of plaster models, and I still have thousands of them, and I don't know what to do with them. I would have to remove the names from each models if I want to throw them away. So scanning is just this technological advancement is just transforming the whole dentistry because we have much less, I would say, work in a way. Simplification of treatment. This is also a trend, and I'll give you an example from the orthodontic world, because I'm an orthodontist. This is fixed appliance braces here on the left-hand side. Orthodontic treatment is very old. So this kind of braces were used before 70s. In 70s, composites were developed. But before that, each orthodontist had to work like a jeweler, had to make own braces, bands with brackets. It was very difficult to make orthodontic appliance for patients. That means that the market, the number of orthodontists willing to work as orthodontists were rather limited. It was very expensive treatment. And then the patients, not so many patients could have afforded it. With time, we got brackets and composites. It was much easier to glue them, to attach them to the surfaces of the teeth. So it was a step forward, the simplification of treatment. Treatment was more affordable, more patients could have afford treatment, but also many more dentists could have specialized in orthodontics because using these braces was easier than making bands for each patient themselves. And the next step in a simplification, I would say, is a gigantic step, was development of clear aligners. And this is a very simple method. So then the market grows because even not experienced dentists can use this method for treatment. They just pop it on the teeth. Sometimes you have to make attachments on the surfaces of the teeth, but in general, this is extreme simplification. And this trend will continue because with simplification of some treatment technique, the potential market for entrepreneurs, for companies, is getting larger and larger. And probably the ultimate simplification of treatment is so direct-to-consumer orthodontics. That means that the patient does not come to the dentist, to orthodontist. He or she comes to scanning center, and then after a few weeks get aligners at home. Why? And actually, when you ask patients that are using this system in America, they are pretty happy with that. We buy stuff on Allegro. We got our purchases at home. It's very convenient. For some very small problems, it's a fairly, I would say, acceptable method. The problem with this direct-to-consumer, for us, the problem with direct-to-consumer orthodontics is that we are omitted. We are not part of the chain of the treatment procedure. And in some cases, in many cases, it can be dangerous for patients, but for many, probably it will be very successful. So this is the ultimate simplification. Then, evidence-based treatment. When I ask dentists, and I know that not all of you are dentists, but let's imagine that we have a patient. This is a young child, let's say 5 or 6 years old, having caries in several milk teeth. And if I ask you which treatment is the most effective, and I'll give you 3 options. The first option would be caries removal, restoration, so filling, and prevention. Prevention is described here at the bottom. What's the prevention? Second option is biological management. So you do not remove everything. You just seal in. So you just cover the caries and you do the prevention and then prevention alone. So if I ask dentists, orthodontists, which option is, in their opinion, the most effective one, I would say 99% or 95% of them say the first one. So the normal dental procedure. We see the caries, we want to remove it, we want to make a filling, and that's it. But if you do a randomized clinical trial, and this one was done in UK and published 4 years ago, it turns out that there is no difference. So you cannot do anything else but just recommend some dietary changes to the prevention, and you got just the same result as if you do a restorative treatment, meaning removal of the caries and making a filling. And this is a top scientific journal in dentistry, Journal of Dental Research, absolute pinnacle of science in dentistry. Very good trial. And stakeholders that are willing to pay for treatment, insurance, they will require us that we use in our treatment methods, in our appliances, that they are evidence-based. So this is another trend. More and more often, we'll have to support that our claim that our treatment method or appliance is effective, but evidence-based data. Another trend is obvious for everyone. Birth rate is going down and down and down. Hopefully it will stop before 0. So we will have to prepare for gerodontology treatment. It's not so bad. I mean, we have to understand there will be more and more elderly patients. They are limitations. The treatment is also slightly different, or can be slightly different in some patients, but we will have more and more patients. But no matter how old you are, remember, feeling attractive is not the only, it's not a question of only of young age. If you are 50, if you are 60, if you are 70, you also want to feel attractive, be perceived as attractive person. So this aesthetic treatment will also apply to this all elderly patients. Fine, then collaboration. Technological advancements require that if you want to do research, you cannot do this as an engineer, you cannot do this without a clinician, because clinician should guide you what's important, what kind of area, what kind of field, what kind of question you would like to ask doing your research. So development of technological appliances, treatment modalities is possible only in collaboration. And then quick sharing of information. It's very important for marketing. It's very important for influencers, but also important in situation when you have a new product and this product is not fully proven. This is an example, what you see here, Acceladent. There was an idea that if you use a vibrational force during orthodontic treatment, teeth will be moving like crazy. I'm exaggerating a little bit, but the treatment time will be much shorter. Those who were treated orthodontically know that one of the most difficult issues for patients to accept is the length of treatment. It will be much nicer to have shorter treatment. And this vibrational force was supposed to speed up treatment. It turns out that Acceladent is not working. Vibrational force brings nothing to the treatment. So the company that is producing this, their profits dropped and the market price dropped dramatically. So my wife is a dentist. Sometimes she does endodontic treatment. Endodontic treatment, that means that you have to fill the canals in a tooth, and this is in teeth with many canals, many roots. It's kind of a difficult task sometimes, and this is a working conditions. These are working conditions of an endodontist. So, see here, this is not my wife. This is just a picture from the web. This is a microscope assistant, and she's getting ready for endodontic treatment. My wife sighs from time to time, had I only a screen with a tooth that I want to treat, visualized with roots, with canals, and that is able to be manipulated, rotated with hand gesture. But the endodontist wears gloves, wears gloves, so it's not so easy. I'm sorry guys. Endodontist wears gloves, so he cannot touch any keyboard and a mouse. So, and imagine that the tooth that this endodontist is supposed to treat is has a complicated root structure. Many roots, many additional roots. If a dentist can see this before treatment or can see this during treatment, most likely this treatment would be much easier, more effective. And imagine that instead of assistant, she sees this tooth with a visualized canal system. This is a Sony. You cannot buy it in Poland yet. In America, I don't think so yet, but that was got a few awards. The Sony 3D display. So when you look at it, you see the picture in 3 dimensions, not on a flat screen. So can you imagine that the endodontist, my wife, sees this 3-dimensional tooth with clearly marked canal system? She cannot, wearing gloves, manipulate it. Then likely the treatment would be much more effective. And that was just a case, just an example how a small improvement in treatment methods could make life of the dentist easier. So if I want to summarize my short presentation, I would like to conclude that demand for dental treatment is expected to grow. So if you want to invest, if you want to stay in the dental business, but understood very widely, not only as a business, but also as a research, as a practice, then it will grow. But there will be a continuous shift toward aesthetic-focused procedures. Many technological innovations in dentistry can be implemented universally. If you're an entrepreneur, if you're an innovator, if you devise something here in Poland, it can be applicable, it can be used by the dentists in Nigeria, in Indonesia, in other countries. The adoption, there's much talk about AI, and I didn't want to talk too much about it today. But remember that adoption of AI in dentistry will expand, but may face challenging due to limited access to high-quality data. AI needs data to train algorithms. What does it mean? For example, if we don't make an experiment, which method is, like I showed you, this one with treatment of baby teeth in the paper from Journal of Dental Research, if we don't make an experiment proving that one or the other method is effective, the AI cannot devise it itself. Remember about this limitation. And testing innovations in clinical setting can be challenging. We need collaboration between researchers, clinicians, innovators, entrepreneurs to see if the product, if the method is effective. And sometimes clinical testing in a clinical setting is quite difficult. In Poland, what I see that there are many ambitious clinicians and engineers to motivated to innovate and contribute to the evolving Dent Tech field. I have experience with life and work in the Western Europe, and I must say I have children that are studying at the moment, and the difference between, for example, Swiss 20-year-olds and Polish 20-year-olds is that we have energy, we have ambition, we have dreams, much more ambition, much more energy, many more colorful dreams than Swiss kids, I would say. Collaboration between stakeholders capable of bringing dental innovations to the market remains insufficient. It's all, and the last one is all about money and organization. We don't have resources. We don't know how to transform, how to bring innovation, the results of our experiment, of our idea, to the market. Because if you are a researcher, if you have made several clinical trials, if you have published 100 papers, you know how to do this. But the next challenge to bring it, to help other dentists, to create a product is a completely different challenge. And we are together here to discuss it, how as a whole country, as a dental field, can be more effective in bringing ideas, our Polish ideas, into life. Thank you very much for your attention. I hope you're still awake. Who needs a coffee before the next step, next presentation? No need for coffee. Okay, thank you very much. So now, thank you. We'll have a time for questions. So I think that's more reasonable, and that we will go on with our presentation. The next presenter will be Professor Skucha-Nowak from Śląski Uniwersytet Medyczny, Katowice or Zabrze? Is it Zabrze? In Katowice, okay. Or about the faculty in Zabrze, and the title of her presentation is Dental Infiltrant, Painless Treatment for Tooth Decay. The floor is yours.
Okay, and pointer. Okay, thanks a lot. First of all, I would like to say thank you for invitation, Professor Fudale, and everybody which are involved in organization of this event. It's first time for me. I do something or not with presentation, because wprowadzenie klucza produktu. I have two presentations. First presentation is connected with dental infiltrant. It's my first child. Okay, we have to wait for presentation, yes? Time. Przerwa, break. Okay, I don't know why. It's presentation. Next is the film. I'm sorry, it's technological affairs, but I think so that it will be last one moment and we will be home. Teraz jest wpisywanie 10 haseł. Państwo tego nie widzą. OK? What's its microinvasive dentistry? It's based on the assertion that an early white spot lesion can be treated in non-invasive manner. It's area of conservative dentistry. We know as a dentist that it's very important to identify the lesion in right time, in right moment, and isolate from bacteria. If we don't do that, next stage, it's damage of the enamel, and at the end, we have surgical treatment. Unfortunately, in Poland, I don't know why, dentists not often choose to apply the infiltration method. In the literature, we know that when we decide to use an infiltration technique, we should use low viscosity polymer resin-based materials to reach reducing or even healing enamel damage. It's only one step when we can do this. One available in the market in Europe product called Infiltrant, it's Icon. It's a German company manufactured a few years ago, DMG firm. This is a lot of future of the product should possess to deserve the title of Infiltrant. One of them, its bacteriostatic properties. None of the available in the market low viscosity resin or even Icon doesn't have these properties. This is mentioned me to start the study in this area. Main goals of my study, I decided to develop an original formulation, synthesis and evaluation of the effectiveness of penetration into demineralized tooth tissue. I have set a following goals for my research. First step was to detailed analysis of low viscosity resins available in the market. I decided Excite, Luxatemp, Glaze and Bond, and Icon. As I said, manufacturers don't disclose detailed information about the composition of commercial products, but none of them have any element which is connected with antibacterial or bacteriostatic properties. I decided to add some elements. I decided on metronidazole. Next step was to selection the material for research. I was thinking about bovine teeth. I was thinking about artificial blocks, but I decided to use human teeth. In spite of that it's very challenging and uncooperative tissue for researcher, but in my opinion, it's only tissue that I can provide reliable results. I decided to use model chemical in vitro demineralization. And it was first zonk, first slip up, because I forgot that experimental preparation and Icon doesn't have any color. I decided to use electron microscope, and I didn't see anything. I should go back one step and focus on optical microscope. I was thinking about kind of dye, and I decided for eosin, and it was a very good choice because we can see the area of penetration of experimental infiltration and Icon. On this stage, I concluded that the developed experimental preparation penetrates into area of enamel and tissue. I came back again to electron microscope, and I decided to use radiological contrast with ytterbium fluoride, and it was a good choice because it significantly facilitates the observation. As a periodontologist, I know how important it is to protect the root cement from caries diseases. I decided to infiltrate hard dental tissues, such as root dental cement and root dental dentin. These tissues are disclosed during periodontal diseases. Before that, I decided to analyze the cytotoxicity. This is the infiltration of root cement. And analysis of cytotoxicity, I decided to use line L929 mice fibroblasts. It's a little schedule. And I conducted cytotoxicity of the experimental preparation after 24 hours is similar or lower than the cytotoxicity of commercial preparation of icon. Based on this preliminary research, I made a decision with my colleagues to file the invitation project titled Dental Infiltrant with Polish Patent Office. I prepared this presentation about 10 days ago, and it's information from 3 days ago we have this patent. I'm very, very happy. It lasts 5 years. Next milestones I'm thinking about. I don't know if I'm thinking about good or wrong. Its optimization of the formulation is extended in vitro study. Its study of mechanical properties, its assessment of aesthetic and patient comfort, collaboration with clinicians and phased first clinical trials, scaling up production, certification and registration of the medical device, and development of a commercialization strategy. My previous research in field of microinvasive dentistry has been published, and in field of experimental infiltrant since now too. Thank you. It's my first child, and I don't know, maybe the discussion after the panel, because any questions now or after the panel in couloirs? What do you think? What do you prefer? Maybe after. Okay. Second presentation, it's my second child with my colleagues. One of them is here, Mr. Przemysław Jędrusik. We have one child. Yes, I would like to introduce a new tool for dental study, for dental education for students. It's a virtual dental office. It's a very interesting tool for us as a teacher. We made this at the start. Student can be inside, he's involved in treatment process during preclinical study. We decided to make a film because, in my opinion, it's better than presentation, and we take this tool with us. It's in exhibition room, and I invite you to try and see what students see, what we as a teacher see. It's a modern tool for preclinical practice when student is involved in the middle of the teaching process, he is able to make his first diagnostic decisions without his colleagues, without us as teachers, because he has a Google, and he's alone in this dental office. We have about 300 pieces of our dental office. We try asking students, for example, prepare a set for extraction tooth 1-6, and he has to find. Please check if in the area of conservative dentistry we have every pieces for filling temporary cavity. And now we are during organization the pathology in oral cavity, and sometimes during study, 3 years in our university, students has contact with real patient, 3-4. Sometimes we have very rare diseases, and he's not managed to find or meet these diseases. We will have here. In our opinion, it's tool for education, not only for dentists, but it's a tool for education of assistant, for hygienist, of organization, the dental practice, to use the autoclave. We have all programs of autoclave. It could be conducted or with dental radiology. We can imagine that we write a scenario of diagnosis and cavity and healing or calculus in oral cavity, and student can see it on orthopantomogram too. This is the waiting room. As I said, we have over 300 models now. We are still working on that. Jeszcze była muzyka, ale nie ma. I think that it will be best for you to go and try. Okay? You will see what we can use, what kind of possibilities of this tool. And we as a teacher, I think that it's moment can we support the student. We not tell him, do this. We ask him, and he has to think. In my opinion, it's a tool for teachers too, academic teachers too, but because every teacher has to improve his knowledge about new possibilities in teaching and innovations. In our opinion, it will be very useful for use during the OSCE exam. because it's very objective, and we have information back if students do well or wrong, failed or no. Prepare the diagnostic set, not like in clinical, during clinical practice, when the assistant give him the diagnostic set. No, he has to do this alone. As I said, the usability of autoclave, we have whole programs. They can practice to use. And it's safe patient. Our patients are safe. On this stage for students, on this stage for knowledge. What are we thinking next time? About multiplication in contact with patient, we are thinking to develop for childs. We know that children are very afraid from dentist, dental office, dentophobia sometimes. And we are thinking that it will be very useful tool for childs too. What's the next goal? Live multiplayer with assistant and student. Few places. Adaptive use for children in waiting room. Patient-student communication and soft skills. Training soft skills. This is our Intuitive and Innovate education tool. Thank you. Thanks a lot.
Thank you very much for the presentation, two of your children. I have a question regarding the second project of yours. How do students respond to this virtual dental office? Do they like it?
Yes, they like it. You know, students are very young people. Not like me, but very, very young. And for us, it's first time when we was talking about that with Mr. Przemek. I was thinking how students invite this, how they think about it. It's great tool for them. Believe me. They are involved in process since second year. Now I would like to involve this tool education on first year during practice of ergonomy, organization of dental practice. They like it very much, and I have a feedback that przyzwyczajają się. Yes, getting used at this stage. And for them, it's very good tool. Okay, thank you.
Thank you very much. So, the next speaker, with her own child, is Professor Dominiak from Wrocław. And presentation of Professor Dominiak is titled Personalized 3D Bone Reconstruction in Maxillofacial region. The floor is yours.
Thank you, Professor, for the invitation. Thank you for nice introduction. And I would like to also thank you all organizers for to give us the floor for me and for Professor Gadrange, who is co-author of this presentation also. So probably it is the same problem with the presentation because I couldn't do the next step. Probably it is visible. So one moment, please. Yes, it's great. I can see. So, as I said, the Professor Gadrange, who is the professor at Wrocław Medical University and Oral Surgery Department, or also Technical University of Dresden, he's orthodontist. I am a surgeon, so we are together create the model of personalized bone reconstruction. Why it is important? Because in dental surgery, not only in dental surgery, you can find so a lot of different bone defects. There are periodontal bone defects, perio-endo lesion, and also after tooth extraction, we can expect in few months, sometimes 2 years, completely loss of the bone alveolar ridge, of course. That's why we need to have some tools, so some materials or the methods for bone reconstruction. Why? Because people would like to have nice smile, as Professor Fudalej said. They would like to have nice face, nice smile, white teeth. That's why it is really, really important. So you can find a lot of different materials. It can be divided on bone materials and non-bone materials, and of course on bone block and particles. So it is really important, and that can come from the animals, and of course can be harvested from the humans. That's why we can have so a lot of different ones. But also we can do some procedures on our alveolar ridge or another type of the bones, not only connected with the oral mouth, but also we can do take some grafts from the hips. That's why we have different procedures, but the question is which one is the best one? So maybe in case of the tooth, in case of the gaps without of the tooth or the teeth, we can do so a lot of different procedure as a surgeon, but it is the question very, very important for the orthodontist. Because when this type of the patients can come to our office, we can ask what we can do, what we can propose for these patients. And sometimes it is really, really important. You can find the patients during the auto treatment, and what is the questions for the surgeons or for the periodontist? Because it is the problem of the movement on the tooth, because you couldn't find the bone surrounding the tooth. So another cross-section, it is really, really important. The bone, it is really on the top of the apex of the tooth, and it is impossible to move of the tooth because you couldn't find the bone. Tooth should be moved in the spongy bone. It is the indications for the proper movement. That's why the proper indications and proper recognizing the bone dehiscences is so important. The bone dehiscences can be divided on two classes. One, it is visible one, when it is very easy to find. That's why we are called them as a recession. And the bone dehiscences, it is impossible to find them in the clinical examination. That's why the X-rays as a CBCT, it is really crucial to provide it for the patients. So we can find also a lot of classification describing bone dehiscences, and even our groups propose new modification of this classification because of the disappear bone on the lingual side, especially on the lingual side, which is very, very frequent in our region, and especially in the Europes. So where is the problem? And when we try to find the answer, when we put the questions, the problem is in the position of the tooth in alveolar ridge. And In case of the particular tooth, it is completely outside of the bone envelope. So what is the proposition for the patients? Of course, we can say we can extract all of this tooth. But what was the reason to do the treatments when we should extract after the ortho treatment? That's why we invent the bone reconstruction, personalized bone reconstruction for such particular cases. It is protected by international patent, and we also obtained gold scalpel as a very prestigious prize in case a few years ago. That's why I'm so happy that it is possible to present in this podium. So let's go to the case. She came to me, to my office, and once again asked me to help her. And in this cross-section, you can find some problems, but it's not so severe. In the sagittal direction on this side, you can find huge problem in orthodontical point of view. And especially it is important when we start analyze the X-rays. On the 2D, as Professor Fudalaj said, it is impossible to find so many details. It is much more visible in the lateral X-ray, but especially on the CBCT, you can find this huge problem, especially on sagittal cross-section and the position of the upper incisor. It is completely in incorrect position. You can find discrepancy between the lower and upper jaw. It is much less than the lower one. That's why also on this occlusal cross-section you can find that it is not so much bone in this position. And that position, as Professor Gedranger said, it is the proper one for the ortho treatment. The tooth should be in that particular position. That's why we have so much less, we don't have the bone on this area. That's why we need to propose something for our patients. And we propose several steps. The personalized bone, preparing of the personalized bone, the few steps during the surgery. It is not working. Oh yes, some steps. And shortly, I would like to present you how it looks like. You can find the information of this type of the computer program. You need to prepare this block as precise as possible. You can draw different lines because sometimes you can have the smaller one or bigger one in different cross sections. It is really very important and so much important that you need to prepare the bone in 3-dimensional direction, in the vertical, occlusal and sagittal one. So it's really a little bit time consuming as this type of the computer programs, but also it is precisely described in this publication. The next step, it is the milling and cutting. It is, of course, the allograft. It is really important that it's coming from the knee. It is the special type of the bone because of the loading of the bone in this moment. And it is especially the structure of the bone is much more precise to preparing this type of the block. Not especially, it is not so good when it is harvested from the hip or another region. So you can find in this moment very precise prepared of the bone block, and especially with this type of the concavities on this internal part, and the external one, it is much more flat, which is precise for the bone reconstruction. And very shortly, you need to remove the periosteum, and after that you need to remove filling if it is existing on this place. So maybe your idea, it will be good for the protect the cementum in this place. And after that you need to prepare the cortication, put the bone screw it using the titanium screws. And after that, of course, it is important management of the soft tissue because of the release the tension in this place. And finally, you have this type of the effect. Completely rebuild the bone in this place. Of course, it is provided CBCT directly after the surgery, but you can find it's really precise, located in the bone defects. That's why in different direction, not only that one, but you can find also in this cross-section. And another smaller cross-section, and it's really the same in all these particularities in the frontal part. So it is also very important from another our studies on animal studies that the dimension of the bone should be not only the bone, the space between the bone block and the recipient sites should be lower than even 1 millimeter. So it is really important for the proper vascularization. So the personalization for this block, it's really crucial for the effectiveness of the treatments. And it is histological study, it is really true bone in this area, and the magnification, the higher magnification, and you can find really only the osteoblasts and osteocytes in this area. So very quickly, the final, not this patient, the another one, after 1 year, you can find the same steps, the preposition, the bone blocks, and after 1 year, you have completely new bone, spongy bone, and the compact bone, as you prepared during your planning. So it is really quick, easy, quite quick to obtain. The another questions, if maybe we can do it another methods, using the another methods, maybe yes, and simply the same type of the problems in this time in the lower jaw, and of course you can put the allografts, particles allografts, and of course you can obtain increasing vertical dimension of the bone, but look, it is not so spongy bone. It looks like the compact one. It is really higher density of the bone in this cross section. So it is possible to obtain this type of the result, but when we compare two different cross section, it is completely different one. Because of the cortical bone, it is not present after 1 year observation. The spongy bone, it is only on this area. The density is lower than in this moment, and it is the crucial for the auto treatment, as I know, Professor, yes? And another, the structure of the bone, it is so important because we have the spongy and compact bone, shape of the bone is the proper one. Another point, it is so important for orthodontic point of view because of the existing B point. We don't have the time to discuss them, but it is really important in this area. Still we have on the same level, even after the reconstruction. And maybe we can use the xenografts. Yes, of course, but looks like, how is the density looks like, and the position of them. It is completely not the proper reconstruction, even in surgical point of view. So the last case which I would like to present, it is exactly not mine, but it is based on this analysis. It's possible to take the bone from the hip, as I said, but it is the second surgical site. It is, of course, the unpredictable resorption because of the different type of the bone due to the embryological idea. And it is also the limited availability of the bone for the grafting. And please find some cross-section, some slides describing how it looks like. The second operation field, it is really not so easy for the patient. Finally, we can put these plates on the alveolar ridge, put some xenografts. Of course, you can do it, but it is not the simplification. The simplification, it is idea, the modern dentistry, as also Professor Fudalaj said, it should be so easy and predictable for the patients. So I would like to say that the method should be personalized, predictable, easy, and quick. Thank you very much for your presence and listening to my lecture. To attention, I would like to say. Thank you.
Thank you very much. I have a question. Well, are there any questions from the audience? Yes, go ahead.
I think so, because it is the future of our analysis, and I hope so to find more details, especially the periodontal ligaments and something like this type of the anatomical structure. But till now we know that the X-ray loading, it is, for instance, for the CBCT one, you're traveling from Wrocław to Tokyo. It is the dose which is the comparable for simple traveling when you are flying. Also with children, we are flying. So when we're thinking about so much personalized bone, and especially that the bone is growing with the children, because it is the spongy, after 6 weeks, it looks like after the fracture, it is completely healed. It's growing with the children. So if you decided as a parent, as a father, to take the children to the plane, you can decide about the surgery and to doing the X-rays.
Shortly, the idea is very good. MRI is very good, but
let me introduce Professor Gedrang.
From this picture, when you use CBCT, the cost of the investigation is about 100 zloty. But when you use MRI, it's very expensive. The patient must pay. This is one. The second, when you have children for investigation, when you send to CBCT, it's very easy. When you send to MRI, this is not so easy. The third, what is better, when you use CBCT, X-ray, in the new kind of CBCTs is very low. We need only this part. When you used MRI, yes, but I know, but the investigation field is very low for this kind of recognition. In orthodontic, I make panoramic X-ray, 1 year, and cephalometric. This is much more like small CBCT. Yes.
In my point, it will be the future, but I know that it is really on the line because we discussed with Professor Ingrid Różowa-Kalinowska, and some even papers, it is well written, and in my point of view, it will be the future, but till now we have this easy, predictable tool, and I think it is not so hard, even for the children.
When you say the future, you mean MRI?
Yeah.
Okay.
Exactly.
One more question. You harvest the bone from tibia, right?
No, from knee.
From the femur.
From the knee.
From the knee. Okay.
It is so important because of the structure of the bone. It is much better because of the loading of the bone, yes, and the density of the bone.
Sure, but when you say the knee patella, you mean femur?
No, it is the upper part. I don't know how, in anatomically point of view, how it should say in English, but it is the one of the part with the bigger, because the dimension of the bone you can have for small one, but also you have to, for the 12, covering 12 bone dehiscences on the 12 tooth, of course, teeth, sorry. So that's why it is important to have the bigger structure for preparing this type of the bone.
Could you think of printing the bone block? Is it possible?
Yes, it is possible. Even our friends of us in Jamil Shibli, he's Brazilian guy, and even 2 weeks ago we were there, and he has on his factory, Plenum it's called, and he printing so a lot of bone blocks, but that one it is impossible. He said with his oral surgeon also, because of the not possible reconstruct to the sponge only for the spongy bone. It is reconstruction rather for the compact one. It is possible to load the implants, inserting the implants, finally the loading, but in this point, it is, for his point of view, it is impossible to do exactly the same.
Okay, thank you.
We have 2 kinds, printing and milling. Printing, we use hydroxyapatite, but for the bonding of hydroxyapatite, milk acid, and to bond hydroxyl to hydroxyl. And milk acid is very complicated to loss of the teeth region. We have only hydroxyapatite without any component, this one. And we use this knee of the patient who have changed after sport or another diseases. We have many. About in Poland is about 100,000 surgeries on knee, and we have many.
The structure is, as I said, so important because it is important to have the hydroxyapatite and collagen. Still, it is existing the collagen because on the contact with the CGFs, bone, the bloods, and this type of the cells. So the effectiveness, I think, it is the connected with this type of the material which we can obtain.
Okay, thank you very much.
Thank you.
A very nice presentation. And the next presenter is the missing one. The missing one is Michał Iwański. So the next one is Anna Wójcicka, also missing one, but we have a Professor Jaworek here, Koriatowska-Jaworek from AGH University, and she will give us a presentation titled A New Era in Dentistry, Precision Root Canal Treatment Enabled by AI. Okay, go ahead, Flora, the floor is yours.
Thank you very much. I think I have the same problem as before, but oh my gosh, it's so good to be here. To be honest, I'm a computer scientist, so I had no clue that there can be such big problems with the teeth, and I always thought that it takes like 1-2 years and everything will be fine. Oh, okay, so I will bring you to a different word, but I don't know why it looks like this. Can you somehow help me with the slides? Okay, so I think we have to wait. Yeah, so I would like to say that I will bring you to another word. I think most of you are clinicians, so I will speak a little bit more about AI and deep learning. I'm the director of the Center of Excellence in Artificial Intelligence. And thanks to Piotr, we've been involved also in the topic of dentistry. So I will show you some results that we have and projects that we are working right on. So the first thing is we are speaking a lot about new technologies and the advancement in healthcare. But I think we are not speaking enough why we are facing it right now. So here I want to show you and just give you the idea of deep learning. So mostly we are not really in the area of artificial intelligence, but only a small part of artificial intelligence, which is called deep learning. Deep learning means that we have a lot of layers, and those layers give us the opportunity that the features are not extracted anymore, but are extracted by the neural network itself. So we have the possibility to work on an architecture that is more computationally complex. And since 2010, 2012, we are able to solve problems in computer vision, so in radiology and other kind of imaging, which we were not able to solve before. This is very important. The amount of problems that have not been solved before is enormous, and the accuracy that we are now getting with AI, especially with deep learning, gives us the possibilities to work together and to show you some solutions that can help you by your work. So the AI tech has the boom of AI tech will come around the year 2026, 2027, up to 2030. We can observe that right now we are really at the beginning. We are at the beginning because of many reasons. The first one, we have no data sets that are ready for regular training of AI systems. AGH is partner of the Regional Centers for Data Imaging, so we are working with different hospitals in Poland to build data sets that will be correct with the European regulations regarding AI Act. So we can observe that starting from 2025-26, the amount of the market, so of the applications that can be sold, will be much higher than it is now. The second thing is that now the regulations are there, so it will be much safer for the computer science as well as for the healthcare services to put such services on the market. And the third thing is that it takes time that we get familiar with all these opportunities that we have on the market. So we observe that during the next few years, the AI will have a great boom. And the same will be in the dental imaging. We observe that the market size is growing in this area. During the speeches before, we saw that not only imaging, but also virtual reality, augmented reality, programs that can help during trainings, teaching, will play a huge area on the market. I can't agree with the diagram by technology. I'm sure that deep learning take the most of the cycle because this is the technology that gives us the opportunities to move further. So the problem that we are working on, as Piotr described during also his presentation, is an integrated dental platform which will not only segment each teeth, but also segment the root, the canals, and also be able to visualize it in 3D as it has been shown before, but also, for example, evaluate the procedures and show what has been done correctly and where are something missing. So we have done different steps during our project that is running. So we have done the automatic segmentation. On the left side, you can see such architectures that we are working on to perform the exact segmentation of each teeth based on the CTBC images. One of the very important part of the systems that we are building is the data preparation for the AI engine. So here, the better the data, the better the outcome. So we have a huge private data set which we have prepared for the training process, and furthermore we are performing steps which we integrate that the deep learning network is improving the outcomes from the segmentation part. The better the segmentation of the teeth, the better the segmentation of the canals and more precise. So this is the outcome of the segmentation part. Here we have the individual teeth extraction. We are using advanced image processing methods. Here you can see the segmentation based on the watershed. So each of the teeth can be segmented separately. But as it has been shown before, the problems are much bigger here because the teeth in 3D space are overlapping, and we have to write our own algorithm to separate the teeth and then to count the teeth and give the correct numbers to them. So this process is a little bit more tricky than it looks at the first sign. And Piotr said something that is very important during his presentation, that there's a huge difference between basic research that we are performing at the universities, also in computer science, and about projects when we want to get to the market. The results are much different when we speak about those two parts. In basic research, we mostly concentrate on the algorithm, on the novelty, on showing how it may, let's say, perform better. But when it comes to reality, and when the algorithms are going to the testing, the outcomes mostly are not as good as they are at the basic research. So mostly we come back and we have to rewrite those solutions to make them work in many different situations, and mostly in the situations when they are really like outliers, really rare in the data set. But the algorithm has still to work over 90% in those situations. So based on this and the teeth that are overlapping, we are performing different skeletizations and working on graphs, because this structure becomes for us as computer scientists a graph. And based on this, we are able to distinguish between teeth and to give them numbers. All right, so I move forward. Here I have only 1 minute, thank you. So now I show you the 3D visualization of the teeth. So from our data set, I hope it will work. Give me a second. Oh yeah, and here is the segmentation of the root canal. We can of course zoom out. We can improve it. We can check it on the radiology image. And furthermore, we will be able in the future to compare it between different scans. What are the real differences? So thank you very much, and thank you very much for having me here.
Thank you very much for the presentation. Are there any questions from the audience? Yeah, I have a question, sure. What's the most difficult step in the research like this? I've never asked you this before, but from your perspective.
I think the most difficult here in this part was the differentiation between the teeth. This is the most tricky part. We had a huge knowledge because this is not our first project that is going, or hopefully will go on the market. But so we had some experience before. So a few years ago, I would say the segmentation, but now we knew how to handle it correctly, and we were aware of the iterations that we have to perform. The canal segmentation will at the end not be the biggest deal, but the correct segmentation of the teeth. Okay. And in the last step, the assessment of the differences between the progress of the treatment. Okay. So the correct, putting the teeth together. So looking for the points that will allow us to put it in 3D.
Okay. Thank you very much.
Thank you. Oh.
Yeah, go ahead. Yeah, sure. Go ahead.
Do you think it is possible to describe on the dehiscences as I presented? It is possible to estimate and predictability of the the appear of the bone dehiscences, for instance, during ortho treatment, it is possible to do to using AI and this type of the idea to prepare.
You mean preparing 3D model of the bone?
No, it's just a short explanation. Bone dehiscence is the missing bone, the
Yeah.
part. Okay, I'm sorry.
Oh yeah, so the missing bone, the 3D missing bone. Yeah, of course. Such project is already at the Collegium Medicum, but this is in another topic. It's reconstruction of the of this bone. Sorry, so the head bone.
Temporal bone, yes.
And because of surgery in oncology, some of this bone for kids has to be replaced. So things like this are done. And furthermore, these parts are also been printed. So this is also part for the pre-operation preparation. It's very interesting, and it's doable when we have the data set. When we have the data set from many patients with annotations what happened in the future, we can easily, or not easily, but we can work on finding features from the data set that will relate to the diseases that occurred later. This is why in Poland we have this regionalne centra medycyny cyfrowej that are run under ABM. And the goal of the centers is very similar. So in the huge data set, we will look for patterns that will increase the possibility of showing the future diseases, or for patterns for treatment. Which treatment will be the best for which person?
Yes, I know. It's a great idea because we have one at our university.
Yeah, of course you are.
But
So this
you
is
know
a
what,
possibility for you as the society just to
absolutely.
establish such a data set. One more thing from my side, I know that, for example, Ministry from Digital Civilization, or also for you for health, has money for building such data sets for AI use, because this is in KPO also. So maybe this is something that you can ask for.
I think that's why we are here, because we need to collaborate, different centers, universities, different fields. And for example, those collection of data sets, this is critical for AI development. If we don't have good data sets, and what you mentioned, Asha, they don't cover dentistry. I mean, they don't have CBCTs, they don't have radiographs, they have just patient histories. And it's possible to find some associations or trends, or which word did you use?
Patterns.
Patterns, yes, patterns in the data set. But unfortunately, from our point of view, it's not so useful, I think, because they don't have like radiographs there. So we have to take care of our data sets ourselves.
Yeah, thank you very much. It's also a big opportunity for us as computer scientists. Thank you.
Thank you. So the next presenter is Katarzyna Starzak from Kraków University of Technology. And the topic of the presentation is novel photoinitiators and resin formulations dedicated for the curable dental materials and 3D printing. The floor is yours.
Thank you very much for the introduction. I'm actually a second year student of a PhD, and I wanted kind of to make a presentation about something that is a little bit different than what we have already seen here. First of all, our research in our research group is mostly concerned about 3D printing. So 3D printing has a lot of applications such as architecture, industry, art and culture, and also things such as medicine, so biomaterials, dental materials, and many, many others. And when we think about the composition of dental materials, the most important things are organic matrix, inorganic filler, and the photoinitiating system. So when it comes to the organic matrix, mostly we use already known monomers and other parts. So the things that are mostly of the concern are polymerization shrinkage, mechanical properties, color stability, biocompatibility. When it comes to the inorganic filler, the mechanical resistance, as they alter the mechanical properties of the outcoming composite. What we are mostly working on in our lab, we are working on photoinitiating systems dedicated for different types of photopolymerization process that can actually work within different wavelengths. So that's what we are looking for, and our approach is kind of different, but I will show it in the next slides. So when it comes to the organic matrix, we are talking about like conventional dental composites and also resins that are dedicated to the obtaining of dental materials. The most concerning fact is that mostly we use acrylic monomers and methacrylic monomers, and they are genotoxic and cytotoxic, not all of them, but most of them, and oxygen inhibition also plays an important role in this case. So the risk for the patient is actually a great concern in this case, and that's why we are looking for something else, and that's why we are looking for a different approach, and also the polymerization shrinkage in this case is a major concern. Also, the photoinitiating systems that are commonly used for dental composites with the radical polymerization are two-component initiating systems using, for example, amines and camphoraquinone, which actually absorb in the wide range of visible light. So we can use the traditional dental lamps that emit around 450 nanometers, but camphoraquinone actually generates yellow coloration, and amines are cytotoxic and genotoxic, which kind of eliminates them from the possible use. When it comes to another photoinitiating systems, such as PPD, there is a color stability, but we can only use it within radical polymerization. BAPO and TPO are actually, they're very, very good and very effective photoinitiators, but we can use them within the UV range. But that's not the most concern. The most concerns that we have is the cytotoxicity and the genotoxicity. And that's why these two, which are actually two of the most common used photoinitiators, are actually being back out from the market. And also we have another ones, and they are non-toxic. They have high initiation efficiency, but they only work with acrylic and methacrylic monomers that polymerize due to the according to the radical mechanism. So what we are proposing here is the use of iodonium salts. So they are very conventional cationic photoinitiators, and we are proposing here the use of cationic polymerization for the development of new type of composites, of dental composites and dental materials. So the efficiency of the process is improved with the cationic polymerization. The oxygen inhibition is not the case. Also, the sorption, water solubility, and toughness and the mechanical properties of the obtained materials are better. So, first of all, I wanted to tell you that all of this research is connected with the with the Leader 13 project conducted by Dr. Monika Toparsk-Farczyńska. And the whole idea of the project is to actually develop these new photoinitiators and these new composites, and also apply them in 3D printing. And the main objective here is to make a project and actually manufacture a new type of 3D printer that could be used for, especially for the 3D printing of dental materials. So with the cationic polymerization, there is actually the case with choosing the best monomers. So we need to choose monomers that can undergo the cationic polymerization, cationic ring opening photopolymerization. And in this case, we are actually mostly we look for epoxides or for silurans for the cationic process. The developed structures that we have, because we have developed many cationic photoinitiators that can actually work within the wide range of light, and their effectiveness has been established. They have been established as very effective, and we actually already use them in 3D printing, and we obtain very high quality materials. They can be used in cationic photopolymerization, in IPN polymerization that actually uses radical and cationic monomers. And as has been proven, iodonium salts also can be used with the radical polymerization. And we have also made a lot of assessments when it comes to the composites and to the 3D printing resins as well, because we have already found some of the resins that are that can be applied in dental materials. In this case, we can see that the cationic polymerization is the fastest polymerization, because the gelation time is the time when the sample is becoming a polymer. So in this case, it's one of the fastest, and also the polymerization shrinkage with the use of the cationic polymerization is the lowest. As we can see in all of these blocks, we should have 4 millimeters. And this is the radical polymerization, the IPN, and the cationic polymerization. So the cationic polymerization actually eliminates the case of polymerization shrinkage. So to summarize, our solution is new photoinitiators, new photoinitiating systems dedicated for cationic polymerization. That are completely safe, that have great mechanical properties, and that can be used in many polymerization processes. And we are looking for some cooperation, maybe somebody that has that wants to commercialize it, or maybe conduct some more analysis on the possible use. And our new initiating systems are because this is kind of a new approach to use cationic polymerization in the case of dental composites. We also have a very big research team, and we also have some international and national collaborations that help us to analyze and to assess the outcome materials. And thank you for the attention.
Thank you very much. Are there any questions from you, from the audience? I have a question, sure. There were 2 companies involved in that was the grant that was at least partial finance. The whole project was from MCBR. and there were 2 companies involved. Did they come to you with the idea, or it was your idea? I mean, people from the university.
Well, the whole project started because the manager of the project, Dr. Monika Topa-Skwarczyńska, she started to find new applications of photopolymerization, and she found that there is kind of a problem with the dental composites, and our team was specialized in cationic photopolymerization, and she wanted to kind of join these two, and then she wrote one project and then another and another, and now.
And so this project, this idea has not been commercialized yet, as I see, because you are looking for a company that would be involved in bringing the project to the market, right?
Yeah.
Okay. So it's still open pitch, so to speak.
Yes,
They are looking for a partner.
Yes.
Okay, super. Thank you very much.
Thank you.
So the next presenter will be Dr. Agnieszka Garlicka from Jagiellonian University. She will talk about mixed reality technology for visualizing and enhancing treatment of impacted teeth. Agnieszka, the floor is yours.
Thank you. So my name is Agnieszka Garlicka, and today I would like to speak about mixed reality technology for visualizing and enhancing treatment planning of the impacted teeth. So the purpose of today's short presentation is to show you how we can use the modern technology, which will help us with the orthodontic treatment and obviously dental treatment as well. So, as not everyone here is a after dental university, first of all, what is the impacted teeth? On the picture, you can see the teeth that are going to be impacted soon. They're impacted canine, upper, left and right canine, so the teeth number 3. So what does it mean? That's the fully development teeth, which fails to erupt on direct time. So going back with the definition, that's a tooth that fully emerged through the gums into expected position due to the lack of space in dental arch or improper alignment of the tooth, as it was shown in OPG. So basically what we do with such a teeth, so how do we manage? There are a few steps that we need to think about, but so the first step, we need to create a treatment plan, how we gonna direct, how to direct of the traction, so how we gonna pull the teeth, how to place a bonding attachment and design the appliance to which we're gonna pull the teeth. So there are 2 photographs, upper and lower. On the upper photograph, you can see the impacted upper canine. On the lower arch, on the lower picture, you can see impacted lower canine. They're red colored to make it easier to understand it to everyone. So how we wanna how we wanna design the traction. We've designed it here and show it with the green arch to make it easy to understand. Then placing the bonding attachment. What is it? It's a surgical procedure when the surgeon make it open and make us an access to the impacted teeth through the bone. And then we place the attachment. It can be a bottom, it can be a gold chain. This is the thing that we are gonna, how we're gonna pull this teeth. And then the last one, the appliance, the orthodontic appliance, it is yellow color. This is the thing to whom we're gonna pull it. So as you can see, the visualization is pretty important. Without good visualization, we are not able to make a treatment plan. So we would like to make it easier. So we decided to use the HoloLens goggles. They use the mixed reality to make it easier to see it, because we are creating the 3D image in the 3 dimension. We use the holograms. These goggles, as you can see on the picture, they're quite big, but they're mostly comfortable. They're easy to use, so you shouldn't have any problem with using them. They're quite light. There is a hologram, and you can see also the surrounding of you. So if you're in a dental clinic, you see the patient, and you see your surroundings, and then you see the hologram as well at the same time. This is basically what what an image looks like in the HoloLens with the goggles HoloLens 2. It's a print screen, but to understand it better, I would like to present a case. It's a common case. It's not the most complicated. So here's the OPG. The patient came to the office. That's 12 years old girl. She came to us because she was missing a teeth. That's the teeth number 13, so that's upper right canine. As you can see, the OPG, that's the standard procedures which we conduct with every patient when we are doing the diagnostic. So as you can see with the red arch, there is the impacted canine. And here the tomography, CBCT, which we've done just to know where exactly is the teeth, where exactly, is it to the front of the tooth number 2? Is it to the back? How close is to the teeth number 2? Or is it close to teeth number 1 or teeth number 3? We just need to know how exactly it is placed just to create a treatment plan. So you can see what we see for the computers. Yeah, there are different slides. So basically, it's really hard to know where exactly is the teeth. So when you are a skilled orthodontist, you are able to create a treatment plan. But when you are at the beginning of your orthodontic path, sometimes you need more. So this is what we created. That's the same hologram. That's my hand. I'm using the hologram. You can see it from different sides. Make it closer, farther. You can see how close is it to the tooth number 2, and knowing that, you can see where is the root, where is the crown of the teeth, so you can change the density, so you can manipulate with the object. Knowing all of that, you can create a treatment plan and look for the solution how to treat the patient. So as you can see, the tooth number 3 is really close to the tooth number 2, so what we need to do is like pull it away from the tooth number 2, just not to cause the resorption and make the plan goes really quickly. So basically, it's a really good idea for the orthodontics at the beginning. We also use it by explaining the patients how we're gonna treat them. They find it really difficult without the mixed reality to understand what we're gonna do and how the treatment's gonna be and what can be the complications, which we need to explain to every patient before starting the treatment, just to make them understand the process. So we show it to the patients or to the patient's parents, get their feedback so they can be less scared because of the treatment, because when the patient doesn't understand the treatment, they are getting pretty stressed. So it makes for us the treatment better, easier, and for our patients. Thank you for the presentation.
Thank you very much. Are there any questions? Thank you very much, Agnieszka. I know that you told me that you are a bit stressed, so I will not ask you a question later on. We work together, so I will have time for questions. Thank you very much. As we have 30 minutes and 3 presentations, now we have to stick to the time schedule. The next presenter will be Piotr Pańtak from AGH University. And the title of the presentation is Calcium Phosphates in Biomedical Applications, Future-Oriented and Tailored for Patients. Dr. Pańtak, the floor is yours.
Thank you very much for the kind introduction. I hope everybody can hear me and see presentation. I'm here to show what we're doing with the team led by Professor Tajima. As I said, I'm from Bioceramic Laboratory team. My name is Piotr Pańtak. I'm a PhD student of the Fine IAS. And this presentation will be quite different because I don't want to show any result we have from our materials. It will be more presentation about who we are, what we can offer, and so I think there's something wrong with the presentation.
It's you.
Yeah, it's me. But have to be. I send the PPTXS. I'm not ready for singing or dancing. I can. Okay, I hope it's gonna working this time. So again, yeah, there's a proper slide now. The whole team. Who we are? Let's introduce the team. It's led by Professor Tajima. We are a not big group, but we are focused. We are high motivated team of 4 people. We are all focusing on the calcium phosphates. Calcium phosphates are material used mainly for bone tissue regeneration, also for the dental treatment of the patients. We are together working mostly on calcium phosphates, but each of us focusing on different fields because our group focusing the people from different disciplines, chemical engineers, material scientists, and I'm biomedical engineer. So why calcium phosphate? Calcium phosphate is material we can synthesize in our laboratory, of course. There are many other materials we can use for the implantation process, for healing patient bone defects. But why calcium phosphate are so specific? It's all about the chemistry. The composition of calcium phosphates is very similar. It's almost 100% the same composition as the human bone is. Due to this fact, the calcium phosphates have very unique properties, especially biological properties, because of this composition. They are bioactive, they are also osteoconductive, and they possess excellent properties after the implantation. So there is nothing between the patient and the doctors without the engineers. We are here for providing the doctors and patients with the engineering solutions that can help to get their better health with improved quality of their lives. What we do, as I say, the calcium phosphate is synthesized. We can use them, we can produce them in many different, let's say, forms. It's up to the application. If we need the powders for the implant, we can produce the powders. If we need the granules for healing the bone defects, we can produce the granules as well. It's up to the application, as I said. We can produce also the injectable bone cements for filling the bone after, for example, tooth extraction. It's all about the modification of the materials. In our laboratory, we can synthesize calcium phosphate, as I mentioned many times, but firstly, we have to think what we need for the support the patient outcomes. We can modify as well as chemical formulation on of the calcium phosphate, as well as the morphology of the materials we developed. Thanks to that, we can tailor the characteristic for the specific patient, for the specific need. And what is most important, I think, there's nothing better than being healthy, but if we have so many options of the materials which can be implanted into the patient, of course, the autograft will be the best. There was many presentations about the autografts today, but sometimes the patient condition is not so suitable for the implantation or taking out the autografts. So we can use the calcium phosphate, which are very similar to the natural one, for the healing bone defects after the after the tooth removal processes. If we apply the calcium phosphate on the screws of the metallic implants, we can help with the osteointegration process to bond the bone tissue with the implant surface. As I said, we are a very small group of scientists, but we achieved a lot. We patented our inventions. We showed our invention on many exhibitions, and we are conducting a lot of projects which are focusing on the bone tissue, but not only bone tissue. We are also open for collaboration, as I said. Also, the group have a big, strong publication record. In this year, we just published 10 articles, so I think it's quite big amount for such a small group. Some of our patents were sold to the companies, and they are used commercially for the patient with orthopedics problem, also with dental problems. Of course, as a growing group, we want to learn ourselves more and more. We have also some future plans. We modifying our materials with antibacterial agents such as ions, such as antibiotics. We also divide some, I'm focusing mostly on 3D printing of the materials for the special patient needs. We also incorporated the polymers to improve the characteristic of calcium phosphates. So, thank you very much for this presentation. Here, if you scan this QR code, you can get the, our contact detail of our group. Of course, I'm here to show what we're offering. It's not about the projects. If you working in the laboratory, we can provide you with some powders, with some calcium phosphate, just to make your trial tests, and we can expand them more and more in application to the different projects. Thank you very much for this presentation.
Thank you very much. Are there any? Yes, accolades. Are there any questions? Okay, thank you. I visited your lab. I must say that you are a group of very devoted people, and I was surprised that you can publish so much within such a short time. You see the entrance, the main building of the AGH University. If you have never visited it, go there. It's a beautiful old building. So now, the next presenter will be Christian Bania, air abrasion system, Abrajet. Here you are. Sorry. Painless and vibration-free treatment of tooth decay. The floor is yours. Go ahead.
Thank you. Hello everyone. My name is Christian, and I'm from Air Abrasion System Company. Today I want to tell you more about our project Abrajet. Our team, in collaboration with dental professionals, has developed the revolutionary medical device Abrajet. Our device allows to treat tooth decay painlessly, as a contrast to invasive traditional drilling methods. That's why we believe that it will set a new standard in conservative dentistry. And Abrajet device is based on high air pressure air abrasion technology, which involves acting on caries with particles of abrasion powder accelerated by high air pressure. And this method is an extension of low pressure abrasion technology, which is used in dentistry by dental sandblasters. However, these devices are designed only to remove some bacterial biofilm, stains, discolorations, and they do not remove advanced caries. That's why I believe that Abrajet is a huge step forward in this field. Our device addresses serious social as well as medical problem related to the fear of visiting the dentist. I'm sure that each of us here knows at least few people that are afraid of visiting the dentist. So I think that every one of us know the seriousness of this problem. And as I mentioned, Abrajet doesn't cause any pain during tooth decay treatment. So, for example, there is no need for anesthesia, and there is no possible side effects related to anesthesia. We also eliminate discomfort of vibrations and unpleasant sound associated with drills. We also eliminate other dental drill side effects because our device is more precise than drills. It minimizes invasiveness to healthy tissue. And there is also no cracks weakening the teeth structure. As we can observe using drills. And what is equally important, the Abrajet doesn't cause any negative effect, doesn't have a negative effect on dentist's wrist or hearing caused by vibrations and sound generated by dental drills. That's why I think that I can say that Abrajet is, friendly both for patients and dentists. Our Abrajet technology is verified. It was verified by our team, but also by dental community. In just 12 months, we were able to develop the early production version of the device and also test it against existing reference solution. We also gathered feedback from dental professionals via usability studies to fit the production improvement process. Now we are collaborating with dental professionals and other partners in medical market in Poland. What is very important, we secured our intellectual property. We have field-free patent applications into the Polish Patent Office. And also we register European trademark. And before launching the product into the market, we must make some final adjustment to the device design. Conduct some pre-certification tests like biocompatibility test and perform a medical experiment. We want to also expand our patent protection into other territories than Poland under the PCT procedure. And to give you some brief insight into the market, I will just say, as probably you know, that there are over 2 million dentists worldwide and almost 40,000 dentists in Poland, which gives us 4th place in Europe and 11th place worldwide. And we want to take this opportunity, and launch our Abrajet not only into the Polish market, but also in some other markets with highest population of dentists like EU, USA, and in the further future, maybe also some Asian markets. It is worth to note that we want to develop entire ecosystem of Abrajet so that the revenue will be generated not only from selling Abrajet device itself, but also from selling some consumables like various type of nozzles and cartridges with abrasion powder. And, selecting the appropriate consumables allow dentists to simply to adjust, for example, to the location and size of caries, and it will give them even greater comfort of work. And we estimate that our time to market is 18 to 24 months, and our capital requirement is about 800,000 euros in the first phase and about 1 million euros in the second phase of investment to scale up the sales. And we forecast that cumulative revenue after 5 years of the revenue, we forecast that cumulative revenue after 5 years of sale could be even about 70 million euros. Some few words about our team. Our team consists of dental experts like Zbigniew, who is a concept creator, and also opinion leaders like Professor Aluchna, who educated a few generations of dentists in the Medical University of Warsaw. We have also a team of experienced engineers on board led by Jacek and certification expert Magdalena. We also cooperate with Krzysztof, who has multiple years of experience in international dental companies as a sales director. And our business team consists of 3 people, myself, Paweł, and Adam, and we have extensive knowledge about medical market. And what we are looking for, in addition to financing, we are looking for opinion leaders, like dental professionals who will want to test our device. We are looking for future distributors, and also other partners like scientific institutions and anyone who can support our company's activities. So thank you. Thank you very much, and feel free to contact me. Talk off stage. Then I will be happy to answer any question you may have, and maybe discuss some opportunities for cooperation as well. So thank you one more time.
Thank you very much. Very interesting. It's a Polish company, I see. So it's a Polish, fully 100%
Yes.
Polish. Okay.
Yes.
Congratulations. Fingers crossed for your success.
Thank you. Thank you.
Do you have any questions? Yes, go ahead. Yeah, but we need a microphone.
What's the limit of age when we can use this abrasion?
Generally, there is no limit of age. We can cure we can cure kids, we can cure adults, and we can, cure all classes of tooth decay. But of course, when we are talking about children, because of I'm not a dentist, but the structure of the tooth are,
cooperate with us, yes, because child should cooperate with us.
Yes, yeah, of course. But first, maybe I should say that, of course, the structure of kids' teeth is a little bit different than adults, so maybe the efficiency of our device could be a little bit lower. And when you are talking about, cooperation of the child, I think it's the device is even maybe more addressed to the kids than adults because it's painless, So
adults too, believe me.
So I think that for kids it's not a problem. You can, for example, use device. Show kid on some artificial sample, or some extracted teeth that this device is safe, and even tell them some kind of a story connected with the device that here it is not the drill but the air, and we use as this powder sand like you can play with. Yeah,
that's like adaptive.
Yeah,
yes,
exactly.
Of course. Thank you.
Thank you.
Super. Thank you. We don't have much time. Just 10 minutes for the last presentation, and the last but not least, I had to say that. Marta Kamińska from Jagiellonian University, periodontitis diagnostic system. The floor is yours. Go ahead.
Thank you. I will try to have you out of here as soon as possible. So today I have the privilege of presenting for the first time, publicly at least, our newest invention called periodi. And what are we interested in? What is our main problem that we are trying to solve? We are, to the dentists in the room, I do not need to say that, but I am not a dentist, so I will start from scratch. Periodontitis is a disease where you have inflamed gums. This is soft tissue surrounding your teeth. And in severe cases, it can lead to loss of bone and ultimately loss of teeth. Unfortunately, this is a tricky disease because it often doesn't cause any pain symptoms for the patients. And as we know, we tend to ignore a problem if there is no pain. So patients usually tend to just have gum bleeds and they wait until they come to the dentist when their teeth start moving. So that is pretty late into this problem. That is partially the reason why this disease is quite prevalent, and it's more prevalent the older we get. So we estimate that globally we have about 1 billion cases, which is quite a lot. The added compounding problem to this is the fact that periodontitis is connected with a lot of systemic diseases. So we now know that if we have periodontitis, we are at increased risk of cardiovascular diseases. We are at increased risk of Alzheimer's disease. So if you don't remember to take care of your teeth right now, you will definitely forget later on. We know that periodontitis research and treatment has not really been changing much in the past few decades. We are, of course, working very hard, but the prevalence of this disease is still unchanged, which means that it remains a quite significant global problem. So we have decided to tackle this from the other end, not from treatment, but from the diagnostic side. We already know about this disease that it's caused by specific changes in your bacteria composition of your dental plaque. And so, using that knowledge, we can detect those specific changes using simple biochemical assays. Those assays are designed to detect a specific bacteria that is a keystone pathogen of periodontitis. And as opposed to currently available tests on the market, they are cheaper, faster, do not require any training, any specific training, or specific equipment in the dental office. And we thought it would be extremely cool if we offered sort of like a pregnancy test. You spit on a stick and then you know that you should, for example, go to the dentist because your bacterial flora is putting you at increased risk and maybe you should go be checked out. And now here is where I'm a little bit sad that Professor said that we are leaving the dental impressions, because our professional approach to this test is actually requiring dentists to get an impression, spray the impression with the periodite test, which would indicate to you which dental pocket requires more attention and maybe some adjunct treatment in addition to typical mechanical treatments that you do. So maybe. maybe. So that is most impressive, I think, about this test is the fact that we can tailor it and validate it to the point where we only indicate when there is a problem. Because the microflora is quite similar when we are healthy to when we are at risk of periodontitis. So we only want to fine-tune this test to indicate where we really should go to a periodontist, for example. And of course, since we are tackling an unmet health need, there is a huge potential in the global market for us. Because the diagnostic tests in dentistry are a fast-growing market. There is a lot of potential there, and it's predicted to continue to grow at least for the next decade or so. And just a little bit about the benefits of our test as opposed to already existing solutions on the market. So like I said before, our test is unique because it does not require any specific equipment or training for the professional to use it. You basically spray your impression or patient's impression and then you know right off the bat where you need to give the most of your attention. Of course, the very exciting part is we can also do the test at home in the form of a pregnancy test where we just spit on a stick, which is always exciting for all of us, I guess. And I do know some men that tend to take pregnancy or ovulation tests just for fun. So I hope this is the market we can roll out into as well. The additional benefit of this test is that the result is fast. We depend on enzymatic activity of specific proteases. So we immediately in the office, we do not have to remove the patient, have them go into the waiting room and wait until we develop our result. We can immediately go to work, basically. Our test is developed not just at the Jagiellonian University where I am at, but in cooperation with Wrocław University of Science and Technology, who are our chemistry experts and will help us in designing our specific substrates with dyes that only will show up when there is a problem that you need to tackle. This I will just bypass because, well, that's unnecessary in this room. This is our current team, and at this point I would like to say that we are of course looking for partners. In addition to investors whom we all want and love, we would also love to have more partnerships with dentists, because of course professional support and tailoring the test to their professional needs is our utmost want, so to speak. But in addition to that, we also want to have some partnerships with big pharma companies that are already producing diagnostic tests, because we do not want to do this from scratch when it's not strictly necessary. And we also need partners in the dental office, because to validate this test and adjust it so that you get from it what you need, we need patients and patient samples to test this from. So we are looking for more partners in the clinic so that we get more samples to validate our tests on. And with that, I would like to say thank you, and I hope I got you at least a little bit interested.
Thank you very much. Very nice presentation. That was the last presentation, and we still, yes, you made it. We have 1 minute left, so just a short question to you. Are there any questions to all presenters? I don't see anyone asking questions, so let me just, a few words of summary. Thank you very much for coming here. It was a pleasure to listen to all the presentations coming from different fields. It's always very enriching when we meet and when we cross-talk. We are getting outside of our bubble and we get into someone else's bubble. And this interaction, cross-talking, is always very enriching. Personally, I think this is one of the most important things, to talk to others, other specialties, try to collaborate, try to reach out, try to find partners, business partners, research partners, because it is the only way to advance, to develop personally and as a team, as a company. All the best. I hope I will see you next time in Krakow. Krakow is a special city, not only because it's a very beautiful one, but we have 2 universities of technology. We have a Jagiellonian University with a medical college. We have Kraków. This is a very important place where we have big fairs 1 a year. So this is actually Kraków as a place to get together for dentists, people from dental-related businesses, from innovators, from dental field, is a very good one. And also it's a nice city. All the best. Have a good time today and enjoy the rest of the meeting. Thank you and I hope to see you next time. Goodbye.